out, especially the injustices in society.
Tune into UBC Radio every Friday from 7 p.m. to 8 p.m. and catch the news wrap. UBC, inspiring Uganda.
UBC Radio brings to you the Timeline Radio Show, the space for civic and political rights for Ugandans. Tune in every Monday night at 10:15 p.m. to know your obligation in society as a citizen. UBC Radio, inspiring Uganda.
This is UBC Radio. Tune in for news.
At UBC Radio, we bring you Uganda's latest news and information.
Focus on Parliament.
What we need to do is Prime Minister must give us a position before we finalize the budgeting process.
Enjoy sports. The environment. Politics.
The mission we have is socio-economic transformation.
Health. Entertainment. Updates in education. On the farm. Keep tuned into UBC Radio. Inspiring. Your voice, your platform for exchange of views on topical issues that concern you and our nation.
It is therefore quite comic and laughable to hear of some actors in the world giving us lectures about democracy. You give me lecture about democracy? What are your own credentials?
Join us Monday to Friday from 7 to 8 p.m. as we tackle issues of national interest.
Mahatma Gandhi was a hero for India, but was so much of a hero to the Africans who were struggling to have the liberation. Nelson Mandela was a hero to the South Africans, but more so to the Africans, and more so to the entire world, about how you can fight freedom without actually having to hold the gun yourself and fight. So it all depends. It can be global, it can be regional, it can be national, it can be communal, and it can be family.
Your voice only on UBC Radio, inspiring Uganda. This is Independent Sound.
UBC has 11 sister radio stations spread throughout the country to educate, inform, and entertain. Tune into UBC Radio FM 98, your national radio station, Magic 100, where sports and music is our life. 87.5 Star FM in Uganda, 97.4 UBC West covering Western Uganda, 102 Mega FM in Gulu, 97 FM Butebo Radio in Eastern Uganda, 107.0 Buduri FM, 100.5 Ngea FM in Kasese, 98.0 West Nile FM in Arua, Total Ray Radio FM 90 in Karamoja, and 93.0 Voice of Mundubujo. Now you covered in your local language. UBC Radios, inspiring Uganda.
Welcome to Ground Zero Season 2, a show that brings you in-depth discussion ranging from politics, health, finance, sports, and so much more. Ground Zero Season 2.
We passed it. We didn't know exactly what the problem was on the ground. There is no pretending about the effect of this thing. There's no pretending about that. Nobody showed. It's a problem.
It's balanced.
This is not the stage at which you start planning to tax a commodity like coffee, especially from down there.
It's intellectually engaging.
The Constitution provides that the land must be registered under the National Senior System, which is one of those that supervise farming.
Ground Zero Season 2, live and syndicated on your public and national broadcaster, UBC, inspiring Uganda. Welcome back. Ground Zero Season 2 continues. This is Ground Zero Season 2. Stay tuned. We shall be right back. That was Ground Zero Season 2. April It's Hot. Welcome to Ground Zero Season 2, a show that brings you in-depth discussion ranging from politics, health, finance, sports, and so much more. Ground Zero Season 2.
We That's it. We didn't know exactly what the problem was on the ground. There is no pretending about the effect of this thing. There's no pretending about that. Nobody showed. It's a problem.
It's balanced.
This is not the stage at which you start planning to tax a commodity like coffee, especially from down there.
It's intellectually engaging.
The Constitution provides that the land must be registered under the personal tenure system, which is one of those that's recognized by
Ground Zero Season 2, live and syndicated on your public and national broadcaster, UBC, inspiring Uganda. Welcome back. Ground Zero Season 2 continues. Ground Zero Season 2. Stay tuned. We shall be right back. That was Ground Zero Season 2. A production of Welcome to Ground Zero Season 2, a show that brings you in-depth discussion ranging from politics, health, finance, sports, and so much more. Ground Zero Season 2.
That's it. We didn't know exactly what the problem was on the ground. There is no pretending about the effect of this thing. There's no pretending about that. Nobody showed. It's a problem.
It's balanced.
This is not the stage at which you start planning to tax a commodity like coffee, especially from down there.
It's intellectually engaging.
The Constitution provides that the land must be registered under the personal tenure system, which is one of those that's recognized by
Ground Zero Season 2, live and syndicated on your public.
Well, a very good morning if you're listening to UBC Radio Inspiring Uganda. My name is Licky. Welcome to UBC Ground Zero program, and it's the 26th of July 2025. Well, we are actually just 10 minutes into the show already, and I want to thank you all. If you're tuning into your national radio, remember we are broadcasting live from Kampala, but of course, we are on all the UBC radios, that is 98 FM Aroa's frequency is also on. We have UBC Butebo is also tuning to us. Mbale 96.4 FM Soroti. We are also live at 98.4 UBC West Nile, as well as locked in UBC Magic 100 FM is also locked into us. Thank you so much for joining us. Now today we will be there to strengthening the triple elimination initiative of HIV, hepatitis B, and syphilis in Uganda. And I'm actually in studio, of course, with a lady and a gentleman. First, I have Dr. Linda Nabitaka, the Senior Program Officer, Elimination of Vertical Transmission of HIV, Syphilis, and Hepatitis B. I also have Dr. Kenneth Kabagambe, the ED, the National Organization for People Living with Hepatitis B, Project Director and Triple Elimination Conference in Africa. So we're supposed to be having Dr. Gilbert Sendaula, a gynecologist. Of course, I've been in touch with him, but I think his phones have a couple of issues, so he is not yet here. But of course, maybe if he joins us later, there's no problem. Thank you so much, and welcome to UBC Ground Zero, Dr. Linda. Ladies first. Good morning. Good to have you here.
Good morning, Licky.
Thank you. Dr. Kenneth, thank you so much for taking the time coming to UBC Radio.
Yes, good morning, Licky. I am not a doctor,
okay,
but I'm a public health specialist.
Thank you for correcting me.
Thank you.
Okay, welcome to the show. Real quick, a little bit about yourselves. Let me start with Dr. Linda. We know you are a senior programs officer, and probably there's something else that we don't know about you. Would you really share with us this morning?
Good morning to all our listeners. As I introduced, I'm Dr. Linda Nabitaka. I am a senior program officer with the AIDS control program, and I manage the program for elimination of vertical transmission of HIV, syphilis, and hepatitis B, a position I've been in for quite some time. I am very passionate about issues of mothers and children, and I've been working with this for quite a long time. Yeah, I think that's it.
All right. Yes, Mr. Kabagambe.
Yes, thank you. My name is Kenneth Kabagambe. I'm the founding executive director for the National Organization for People Living with Hepatitis B, a national non-profit organization that was established in 2012 after a great need of, hepatitis services in public health facilities. and also other critical issues that were prevailing at the time, especially stigma and discrimination that those who are tested positive for hepatitis B were facing. And so as a result, we thought we should create an organization that is patient focused. And so we have been in the space for the last 13 years. And from those 13 years, we've been able to have some, services, established in public health facilities. Because by the time we started, we did not have quite a number of services, especially the viral load, which was done majorly by the private laboratories and at a very high cost of 400,000 Ugandan shillings per test, which was very expensive for most of the patients to afford. So through our advocacy, the government was able to establish, free viral load testing at CPHL or Butebo. And so we are glad to the efforts that the government has placed to accord hepatitis B the priority it deserves, though we still have a lot of challenges, but at least we are better off than we started. I am a public health specialist and also I'm a social scientist, so the two blend because they help me to navigate, and also my focus in public health is basically to design effective public health interventions that are acceptable, feasible, and also efficient to delivering effective public health service delivery.
Okay. Thank you. And to the main things now, Dr. Linda, as a senior program officer, elimination of vertical transmission of HIV, syphilis, and hepatitis B, I want us to go back to the basics and the objectives. Can you tell us more about the initiative to eliminate HIV, hepatitis B, and syphilis in Uganda, and what are some of the goals and objectives of this program?
Okay. Thank you. This is a program that we've been running since 2000. In the beginning, we started with majorly prevention of mother-to-child transmission of HIV after a study that had been done here in Uganda by our own scientists, the late Professor George Miro and Professor Philippa Mukasa, which showed that just giving a single dose of antivirals to the baby during labor and to the mother could reduce the chances of the mother transmitting HIV to her baby. So the program started then in only 5 facilities across Uganda. More research kept being done, showing further reduction of transmission from mother to child. We scaled up the program over time. In 2016, WHO then brought out the guidelines that since the same health worker, the same way can be done to prevent congenital syphilis in children, we should run the two together. So then we went into what we call dual elimination at that time. We started running a program of preventing HIV transmission from mother to child and also preventing congenital syphilis. We were able to get a test kit that would test both HIV and syphilis, and then give interventions to the mothers that needed them. Those who are positive for HIV, we give ARVs, the antiretroviral treatment, and those who have syphilis, we give the antibiotics, benzene, penicillin, so that by the time they're giving birth, their children are negative. The program goes way beyond only testing and treating. It looks at ensuring that all the young girls remain HIV negative, so that by the time they are giving birth, they are still HIV negative. It ensures that male partners are also brought on board, that they are tested and that they remain HIV negative, and that they support their partners to consume all the services that we have to give. Then for the mothers who test positive, we do several investigations, including the CD4, like we do for the other adult ART, then the viral load, and then we manage them throughout pregnancy. And we have to make sure that they stay with us until the baby has been tested and found negative at the end of the program. So in 2019, after the country had rolled out the hepatitis program, it was realized that the biggest number of chronic infections for hepatitis actually come from mother-to-child transmission. Almost 95% of people who have chronic infection for hepatitis B acquired it from mother to child. So then we turned our guns to make sure that now we hit all the three. All the three are sexually transmitted. All the three can be transmitted from mother to child. And just by managing this one mother in the same way for all the three, you're able to hit all the three and ensure that this child is born free and healthy and that they are able to thrive. So in 2019, we then started the testing for all the three, HIV, syphilis, and hepatitis B in antenatal. We, scaled up again through trainings. We worked with the Office of the First Lady and, visited all the different regions and popularized the services for testing HIV and also ensuring that the mothers are kept in care and that their male partners support them. So since 2019, we have been doing all the three together with, a lot of progress over the 3 years. And we think we are on the right path generally. Our goal is to ensure that we limit the number of children who are born with the three infections, that we have less than 50 cases of HIV and syphilis out of 100,000 live births, that we test over 95% of the mothers who come for antenatal, for HIV syphilis, and 90% for hepatitis B, that we treat over 95% of those who are found HIV positive or those who are found syphilis positive, and the mothers who get who are hepatitis B positive, that we do a viral load for them and ensure that those who need treatment are given treatment, and that we see that the number of babies born with HIV is less than 5% within the population, which translates to about less than 50 cases per 100,000 for both HIV and syphilis. And we reduce the prevalence of hepatitis B among the children born to mothers with hepatitis B. So that is where we are heading to. We've done a lot to get there, and we still continue to do a lot.
Okay.
Thank you.
All right. Kenneth, the National Organization for People Living with Hepatitis B, as a project director, you are enhancing, of course, trying to push the Triple Elimination Conference in Africa. I want us to go back to your objectives and the goals that you have for the organization. What could be some of the key highlights that we need to know as the audience and also as Ugandans?
Yeah, thank you so much. So for the last 13 years, we have been trying to focus on hepatitis B. But given the funding crisis, and also given that hepatitis B does not attract funding, we thought having an integrated approach into the existing structures like those for HIV would help us leverage and also provide quality and effective services to the people who are living with hepatitis B. So last year, of course, we also had some kind of predictions about the election that were taking place in the US. And it was from that background that we thought maybe coining the Triple Elimination Conference in Africa would bring African Union member states in one space and then objectively discuss on how domestic funding for some of these public health issues can actually be put on table by governments. So it was upon that because we have seen that much as HIV funding has started to slow down, but at least the HIV disease has some good structures, health system structures that hepatitis B can actually leverage on. Because if you look at the transmission, like Dr. Linda has mentioned, it's almost similar to that of HIV. And even its management, because once you're put on treatment, especially those who are eligible for treatment, the treatment is given for life, and that is the case to HIV. So using the same infrastructure for HIV can help us manage better hepatitis B patients in this country. So the focus of this bringing this conference to Uganda basically was to rally political commitment from all the African leaders to commit towards, addressing these issues of hepatitis B, but also come up with a communique which was very important, with actions which can actually be used as an advocacy tool moving forward, especially for the civil society organizations working in the spaces of HIV, hepatitis B, and syphilis. So we believe that those baby steps will help us, enable us to provide equitable health services to all, not necessarily focusing on one specific disease, because the technologies are now shifting from single tests to dual and now triple tests. So given that kind of background, we believe having integrated health approaches will help us reach out to so many people, but also help us to leverage on the little resources, but having a broader impact on the communities that we serve. So that's how the Triple Elimination Conference was coined, and we believe that in the coming few years we shall be able to measure its impact and also see where we have maybe not performed well. But I believe that it's a very good platform for us all to start the discussions on how to provide equitable health services to the people.
Before I let you go, you're championing, of course, the fight against the fight of the hepatitis B. Would you tell us the status of hepatitis B in Uganda and how does it spread that much?
Yes, thank you so much, Licky. So the status of hepatitis B in the country, we stand at 4%, the prevalence of 4%. So if you look at the current population, we have about 1.8 or over 1.8 million people living with chronic hepatitis B. So there has been a lot of efforts that the Ministry of Health and government have been doing. In 2002, the government of the Republic of Uganda introduced what we call the pentavalent vaccine, which targets the babies given at 4 weeks, 6 weeks, and also 14 weeks. So this program has been there for some time. So we believe that probably those children those adults today that were born after 2002 and their parents were able to take them for these immunization schedules, we assume that they are protected against hepatitis B. There, of course, has been a lot of challenges, especially in accessing some of the tests, because not all the tests are done in public health facilities. Yeah, so hepatitis B is a viral infection which can actually be transmitted more like the same as HIV, so through use of contaminated sharp objects, through blood transfusion that is affected. So if you are transfused with blood that has the hepatitis B virus, you're going to get the virus. In some cases, we have seen hepatitis B also being transmitted sexually. It can also be transmitted through mother to child. So if a pregnant mother has hepatitis B during the time of birth, there can be some risk of transmitting the virus from the mother to the baby. And that's why we are talking about prevention of mother-to-child transmission for the 3 infections, because they are transmitted similarly. So the beauty with hepatitis B is that it has a vaccine. So it's not like HIV that doesn't have the vaccine. So if one is tested and they are found not to have the infection, then there is an effective vaccine that can be offered, and then that can protect them for against hepatitis B. Of course, the other preventive measures are again the same as those of HIV. You're avoiding to share objects with people you do not know their status, like the razor blades, and also the shaving machines and all that kind of thing. Then use of protective, like use of condoms during maybe sexual intercourse with someone you do not know their status. That can also help prevent hepatitis B. But the most important thing for hepatitis B, I think, is for us to know our status, because most of the people in this country do not know their status. And it is very hard for us to, prevent ourselves when we do not know our status. And for those who have tested positive, it doesn't mean that's the end of the world. There is always a second chance. The better you go for medical checkups and then monitoring, you can live with hepatitis B for long without having issues with your health. But why are we so bothered about hepatitis B anyway? What is it that it causes in the long run? Because we are talking about its mode of transmission, how it is prevented. So hepatitis B actually can lead to liver cancer, or cancer of the liver if it remained untreated. So the reason why we encourage all Ugandans to know their status in the first place is to ensure that they undergo a series of investigations or tests which will help the doctors or the health workers to assess whether they will need treatment or not. And it is also important to note that not everyone who has tested for hepatitis B positive will require treatment. It's just a portion of those who test positive that will need the treatment, but all that has to be done by the experts or by the doctors. We have seen most people who have tested positive and they have assessed them and doctors told them they don't need the treatment, and they end up running to use herbal medicine. That is very dangerous because the liver filters all the the dirt from going into the bloodstream. So if you burden your liver with herbs which you do not know how impactful they could be to your liver, then you're putting yourself on a high risk of actually developing even more damage on your liver. So we have always encouraged those who have tested positive to always seek medical advice before they take on any drugs or herbs. Yeah, so basically that's what I can say about hepatitis B. Over 85% of liver cancer cases registered at the Uganda Cancer Institute as a result of hepatitis B. Unfortunately, when some of those patients at Uganda Cancer Institute die because of hepatocellular carcinoma or liver cancer, they don't indicate that it is as a result of hepatitis B. So they will only indicate that is liver cancer. So there we may end up not having the exact numbers of people who have died of hepatitis B, but we get them as liver cancer deaths. So that's also something that probably maybe we should address more deeply, so that we know the burden of hepatitis B mortality in this country.
Okay. You mentioned something here and needed you to check the balance. You said it gets chronic. At what stage does hepatitis B become chronic? And we also mentioned about vaccines. I don't know whether these vaccines are available in all the public healthcare systems for now, for people that test negative.
Yeah, so when we talk about hepatitis B, we have what we call acute hepatitis B and chronic hepatitis B.
Yeah.
So with acute hepatitis B, for instance, if an adult or any other person got hepatitis B within a period of 6 months and they clear it, so their immune system has capacity to clear it from the body, and then they test negative, that means they had acute hepatitis B. Now, if the hepatitis B infection persists in the bloodstream for more than 6 months, then that means it has turned into chronic, or it's like a lifelong infection. So that's what we call chronic hepatitis B. So, and the 1.8, the over 1.8 million Ugandan we are talking about are chronic hepatitis B carriers. So the other thing about the vaccines, there are 3 doses of vaccines, especially for the adults, so which are taken in a period of 6 months. For instance, if you started your vaccination today, the 25th of July, you expected to take the 2nd dose after 1 month. That would be 25th of August. Then after 6 months from the 1st dose, then you expected to take your last dose, and there we shall also assume that you have been protected against hepatitis B. So that is what I can say for now. Maybe if there are other questions.
All right. Yes, Dr. Linda, here is another story here. 2 days ago, I read an article about syphilis, which is on the rise, and I think you are really aware about this. Health experts have actually been raising concerns over the rising burden of syphilis, which indicates critical gaps in prevention efforts. This is to you then. Give us a general information about syphilis. And people down there are really doing crazy things. We need to be knowing our checks and our statuses, of course, concerning syphilis right now. What do you have to say about this?
Syphilis, I think, is one of those really old diseases that has been around for quite some time. And unfortunately, I think there's even some pride associated with having syphilis in some of our cultures. And I think it's called something about the hero's disease. So usually when people are told they have syphilis, they don't even take it that seriously. But it's a very serious thing, especially when it comes to mother-to-child transmission. We've seen that, syphilis over time had actually gone down. And, the infection is worse in people who have HIV at about 4.7%. Generally, our prevalence is about 1.4 to 1.5, 2.1 in the general population, and about 1.4, 1.5 in pregnancy. And, because it has not been talked about so much, the way you talk about HIV all the time, people tend not to give it the attention that it deserves. And also because when you get the primary infection, it comes as a wound in some areas, and then it can disappear without any treatment. So I think that's where most of the problem comes. And if you come in the 2nd, 3rd stages, then at that time, there's very little we can do for you. In the 3rd stages, it actually damages the nerves of the body, and then people come with very serious complications. And by that time, most people have even forgotten that the primary problem was actually syphilis. They are thinking of so many other things. So if we treated it at this very first time, when you come with the first wound, then so many things can be avoided. When it comes to mother to child, it's really a devastating infection for the child, the congenital syphilis, if it's passed on to the child. And what's very annoying is that it's very, very easy to ensure that that child is not born with congenital infection. And the syphilis treatment, I think, is one of the cheapest, injection around. It is government of Uganda fully covers the treatment for syphilis for all populations, adult, pregnant women. All the treatment is always available in our health facilities. So it's just that sometimes people don't take it seriously. We've had a big challenge with partners. Many times when the mother comes for antenatal, we shall test her. She will know that she has either HIV or syphilis, but getting the male partner to come and also be tested has been quite a big challenge. And for that reason, we treat the mother, but then the mother goes back and gets back, the reinfection from the mother, from the man. And, that's very, very unfortunate, because treating both of them at a go would really make this much easier for everyone to be cleared. And if the male partner can even bring all the other partners, because usually the male partner will know all the other partners. Partner notification has been one of our biggest challenges across, not only for syphilis, but for all other sexually transmitted infections. And if we could really tie up that knot of partner notification, I think it would really help us a lot. As I've said, either one injection, depending on the stage of syphilis, it has 3 stages. I will not go into those. They are, when you come to the doctor will be able to tell you which stage you are. But just one injection can actually help a lot. But most importantly, because we normally don't know what stage you are when we just look at you and have found out that you have that infection, we prefer to give the 3 injections. Each one is given weekly. You get the injection once a week, and you totally clear the infection. And then for mother-child, even when you give that one injection, it helps to ensure that that child will be born free of the syphilis infection. So if we could go back to the basics, when you see some symptoms of a wound that you don't understand, go and see your health worker. But very importantly, notify your sexual partner to also go and have the tests done, so that all this treatment is done together, and a lot of problems can be averted if you do that. As I said, the mother-child transmission of syphilis, I think, is the easiest to deal with. We've seen that HIV and hepatitis are both chronic infections. The mother has to take treatment for HIV for all their life, even beyond the pregnancy and beyond the breastfeeding. But syphilis, if the mother gets those 3 injections, then, the chances of transmitting to the baby are totally, reduced, and the baby will be born okay. And if we also catch the congenital syphilis early in the child, of course, we wouldn't want to get to that level, because, the child having to go through getting those injections, I think, is really very painful. Yet we could have done something to the mother. But the good thing with syphilis is at whatever point you catch it, mother, early in the child, you clear it totally, and the child can go on to live a good life.
Okay, you tipped us a bit about some of the signs. How can one tell? And what are some of the signs, the general signs and symptoms of syphilis that we should be aware of right now?
Okay, I think the most important is that first sign.
Okay.
When you develop that wound in the area, in the private area, that is the most important sign. We wouldn't want to go into the secondary and tertiary syphilis, as I've said. Okay. Tertiary syphilis affects the nerves. You're not able to walk properly. Secondary syphilis affects the organs of the body, the heart, and so much. So just that primary syphilis, that first wound, just go to a doctor and then get the checkup done. It's one of the very easy diseases to do the lab tests for, and immediately you can get treatment.
All right. Dr. Linda, before I let you go, why is it very crucial to tackle these 3 diseases simultaneously? Why do you think they move together?
They don't exactly move together, okay, but one enables the other. When you, as I said before, for the people who have HIV, we found that there are higher chances of having other infections, because, that means the genital tract has already been sort of damaged by one infection, so it's easier for the other infection to go through. But why it's very important to tackle them together is we've seen the similarities. The similarities in the way they are transmitted, whether sexual or mother to child. It is, it's very similar. They are all sexually transmitted. So because the routes of transmission are the same, we can pass the same message and hit 3 bullets, I could say, with that one. Hit 3 targets with that one bullet. And, it gives what we call like triple dividends, because you ensure the mother is healthy, you treat the infections, then you ensure the baby is healthy, then you strengthen the system, then you bring on board the male partner. So it's even more than triple dividends, because you're getting so much from handling all this together. mother and infant outcomes are improved. You're bringing the male partner on board. You're reducing infectious diseases in the population. You're improving the maternal and child health services that are given at the facility. So there is so much to be gained by handling all the three together. Not only the three now, but now we are even ensuring that all the other infectious diseases, including the non-infectious, the chronic diseases that a mother can have, hypertension, diabetes, that we bring all those
together
onto that platform and manage them together.
Yes, Kenneth, is there any comment you'd like to make about tackling these three diseases simultaneously?
Yeah, first of all, we use the same manpower to tackle these three infections, but more importantly, we also save time the mothers to come back for, if they were tackled like in single approaches. So that alone makes maybe the lives of the mothers more comfortable than, because you will take you will use one single go to provide them with their results than if they would have come back for a single other test. So I think it is very important, and also given that currently we are facing the issues of financing in the public health space, I think handling these infections at a single go provides us the opportunity to ensure that we save the mothers and the children from having these infections.
All right, you're listening to UBC Radio Inspiring Uganda, and we are broadcasting live from across all our sister radio stations. Magic 100 FM, we are in Lira, Arua, Soroti, Butebo. All the other sister radio stations are actually tuned into us, and this is UBC Ground Zero, and the conversation is just about strengthening the triple elimination initiative of HIV, hepatitis B, and syphilis in Uganda. And I have Mr. Kenneth Kabagambe, who is the ED, the National Organization for People Living with Hepatitis B, Project Director, Triple Elimination Conference in Africa, and Dr. Linda Nabitaka, who is the Senior Program Officer, Elimination of Vertical Transmission of HIV, Syphilis, and Hepatitis B. Later on, I'll be able to open my lines in the next hour. You give us a call on 0776 511 426, and you can also reach us out on our platforms. We're on Facebook, Instagram, X, formerly Twitter, and LinkedIn. Share your thoughts on the comment section. We'll be able to read it out to the public. Well, let's go to HIV elimination efforts. This is Dr. Linda. General strategies now. What are some of the strategies being implemented to reduce HIV infections in Uganda?
Okay, thank you. We have been at it for so long, since the early 80s. Some of our things still remain. Primary prevention, abstinence, we have never gone away from that. Being faithful, we cannot stop that. We continue to talk about using the condom, still very, very important. We've added new technologies. We now have a PrEP, which is pre-exposure prophylaxis. We can give it to people who are at high risk of getting HIV infections before they actually get the HIV infections. And, they can utilize it, and it can help to, prevent them from getting the infections. We've just heard about prevention of mother-to-child transmission. We know that over about 18% of infections for HIV are coming from the mother to child. So ensuring that we do the right thing for the mother, test them, give them treatment, ensure their viral loads are kept suppressed, that can help us to make sure that the mothers don't pass on HIV infections to their children. The very, very important is ART for prevention, as we call it. Giving ARVs to people who are HIV positive helps a lot to ensure that the amount of virus they have in their blood is reduced to a very low level that they can't transmit to others. So that is a very big mainstay for our HIV prevention programs. We want as much as possible to know everyone's status. Once we know your status, then we know where to send you. If you're HIV negative, we send you to all the preventive arms that we have. We still talk to you about abstinence, about being faithful, about using a condom, and ensuring that you remain negative, about PrEP if you're among the high risk population, so that you can stay there. Then if you're positive, we give you the ARVs. We monitor you. We make sure that your virus remains suppressed to such a level that you cannot pass it on to all the other people around you. Then if you're a mother, if you're a husband, we ensure that we enroll both of you in the prevention of mother-to-child transmission programs, so that the children that are coming do not have any infections. Yeah, I think that's where we are with prevention.
All right, Kenneth. How widespread is hepatitis B in Uganda, and what are some of the most affected populations here in this country?
Come again, the first question.
How widespread is hepatitis B in Uganda, and what are some of the most affected populations?
Yeah, so hepatitis, like I said, hepatitis B, we at 4%.
4%, yeah.
Yeah, but this is spread not in the same way, because if you look at the region that have higher prevalence than the others, we have regions like Karamoja,
okay,
where the prevalence is almost 4% of the national prevalence. If you go to regions like Acholi, Lango, West Nile, all those regions actually have higher prevalence compared to the national prevalence. And that is why the Ministry of Health in 2015, 2016 started the mass adult screening and vaccination in those regions, because that's where the burden was higher compared to these other regions where the prevalence was a little lower. So that's what I can say. But of course, when you go to Karamoja region, and maybe why the prevalence is higher,
and in Arua,
yeah, if you look at the cultural practices, skin scarification, that would actually propel the transmission from one person to another, because in most cases they do not use sterilized equipment to do the skin skin marking. Yeah. So that's what I can say for now.
All right. Dr. Linda, you talked a lot about the role prevention of mother-to-child transmission play in Uganda, HIV's elimination efforts. I mean, why do you think the role that it plays is very important for now?
The role is very important because we know that that's one tap of HIV that we can totally turn off, and there will be no more free-flowing water from that tap. And for that tap, you tackle the mother, you give her, you test her, you give her treatment if she's HIV positive, you ensure the baby doesn't get HIV transmission, but also the mother remains healthy. And our program really encourages male partner testing. So that means you're handling the family as a whole, the mother, the husband, and the child. So it's a key program in our implementation for HIV program, because it helps us a lot to handle the family as a whole. And it's an entry point into so many other things. Because when you have this one pregnant mother, you're not going to deal with HIV alone. You're going to do all the other things that this mother needs. And because it's easier to get the partner from that way, then you're also going to offer services to the male partner that are going to be very helpful to that male partner. So that is why it's a really key program in our implementation.
I remember you actually shared a bit about going up country, of course, visiting some of the hospitals in some other regions. I wanted us to know about the services in the regional hospitals, for example, in regards to fighting HIV and AIDS, syphilis and hepatitis B. How is it rated, though? How are they doing in terms of, giving the prevention methods and all that?
We are doing very well at all levels.
Okay.
If I could start with the community health extension workers, we've equipped them with the basic knowledge for HIV prevention. They are able to tell you what to do so that you prevent yourself from getting HIV. They are able to to refer and link people to go and get their testing services. They know where HIV testing can be done. HIV testing is done at all levels, starting from the regional referral hospital, even within the communities. We still do some testing in the communities for, where we know that access is not as good as it should be. The health center 2s, 3s, 4s, general hospitals, regional referral hospitals, all of them can do HIV testing. And we know that HIV testing is actually the entry point into the rest of HIV services, because once we know your status, once again, we know, are you due for treatment? Are you due for prevention? And now, we are stressing a lot about testing for prevention, so that for those who are, we know that the bigger part of our population is actually HIV negative. Okay. So we know that for them, we actually need to do a lot to keep them where they are. So all the services are there at all the levels. Okay. There are a few services that you will find at the higher levels, like the health center 3s, 2, 3, 4, general hospital and regional referral hospital. This when it comes to issues of viral load testing, advanced disease. When a person comes very late in their HIV journey, when their immune system has been destroyed a lot, and they have about 200 CD4 cells. Those CD4 cells are the immune response cells. When those cells are really reduced in their body, then they normally come with what we call advanced HIV disease. These are many, different diseases, including TB, including cryptococcal meningitis, histoplasmosis. Those are some infections that come in the lungs, caused by fungi. So these, services for those are at the health center 3s, 4s, and the higher levels. But the other services you can find at all levels, including PMTCT. Okay. In community health extension workers, we've taught them to see these pregnant women, make sure they register them they have registers where they register all the pregnant mothers and the children under 5, and then make sure they are all linked to antenatal care services, which is where now they get the HIV testing and also testing for hepatitis B and syphilis, and they start the rest of the journey. All right, interesting.
Kenneth, let's talk about integration and collaborations. I want us to talk about successful collaborations. Can you share with us some of the successful collaborations between healthcare providers, community organizations that you work with, and the stakeholders? What could be some of the successes that you have registered already in fighting hepatitis B?
Yeah, maybe before I go to that, I just wanted to also highlight some of the challenges with hepatitis B specifically. Okay. Because, yes, we have a very good referral system for HIV, like Dr. Linda said, from Health Center 2 to regional referral hospital. Unlike with hepatitis B, it's very challenging because, for instance, we have seen people who have tested for hepatitis B, especially those that are planning to travel out of this country to the Arab countries. So once they find they have hepatitis B, they do not have like a clear referral system where they can send them, and it's a very big challenge. So and these people have sold maybe some of their properties to go to these countries. So that is a gap that we still have in hepatitis B, and we believe that now with the integration coming on board, all these gaps will be solved, because we shall be riding on the existing HIV platforms like the hub system for collecting the viral load, which is actually happening. But the issue of referring, especially someone who has tested positive in a community setting, to the next level, that still lacks a bit of clarity. And we believe that probably as we move forward is something that we should talk about. Yeah, so the collaborations between the communities and the stakeholders is a powerful tool. Okay. Because you know that everything that we do is to benefit the communities. So our focus is basically to put the communities at the forefront and also engaging them meaningfully, not looking at them as just recipients of these services. We have just been implementing a project on peer support networks in West Nile, and it has shown the power of working with the communities and the affected people. This project was basically trying to relink back those people who had tested positive to the health facilities, because the WHO has recently updated its treatment guidelines to expand the treatment eligibility for those people who are supposed to be eligible for treatment has actually been expanded. So when the program on mass testing and vaccination started in 2005, there are so many people that were tested positive but did not meet the treatment eligibility or criteria that was there then. So, but because of the expanded program, expansion of the treatment eligibility to cover more patients, without going to the communities and using the patient stories to, talk to the fellow patients through radio talk shows and TV talk shows, would help those patients who are were not into care to get back to their facilities and maybe have themselves evaluated again and see whether they now qualify for treatment or not. So such partnerships with the communities can help us achieve more and also can create a sense of ownership, because if you engage the communities or the patients in designing these public health interventions, they feel they are part of them and they will not feel they are meant for them to just be recipients. The other thing, we have seen collaborations work. In 2019, the community collaborated with the Ministry of Health or the government of the Republic of Uganda to host the first African Hepatitis Summit. And this was a huge success. So that showed that you can see the level of achievement of things that we can do if we collaborated or worked closely with the communities and other stakeholders. They just recently concluded the conference, was hosted by the Ministry of Health and other partners like African Union, UNICEF, Unit A, WHO, PATH, the National Organization for People Living with Hepatitis B. And these collaborations have showed that if we come together as a people with a focus on a specific objective, you can be able to achieve them as long as you are working together as a team. So collaborations can make us, achieve more and with limited resources.
Okay. Yes, Doctor. Any other thing you want to share about successful collaborations, of course, between your organization as the Ministry of Health and others? What do you think are some of the key things that we need to be hearing from you in terms of collaborations?
Okay, thank you. As Kenneth has said, I think HIV World, we actually started this whole collaboration with the communities because from the beginning of the response, they clearly told us nothing for us without us. So we started working with them way back in being able to design the program and in most of these policy making forums. So we sit with them on the same table. We tell them what the science is saying, and then we discuss together what is the best way we can go forward. As we all know, the resource envelope is not, it's not stretchable. It doesn't go so far. So many times there's a lot of compromise. One can achieve 95% with the least resources, with everyone on the table. So when you work collaboratively, you bring the aid development partners, because many times they're the ones that are really supporting you to do this programming. You bring the community, then you as Ministry of Health in the leading, in the driver's seat, then implementation becomes very easy. Then your programs become, first of all, acceptable to the population, but also because they've been part of the designing, it's easy for them to tell the rest what is there, what they should get, how they should get it. And then with the support of our development partners, we are then able to ensure that our programs are really grounded and that they are actually happening. So collaboration, coordination, teamwork is very, very important.
A quick one
in programming.
I saw an article yesterday about the UK announcing that they will be, cutting some foreign aid. When Donald Trump also came into power, there was a few cutouts of aid, and the Ministry of Health has actually been benefiting a lot from those countries when it comes to aid concerning health. I mean, what strategies have you put across to fill those gaps that probably maybe will be taken away from you in terms of funding and all that?
We've got a lot of shocks since the year began. Not only the American government, the UK government, and many others that have come up. I think the one good thing that we got is this came after the COVID experience. You remember, in the COVID experience, everywhere was locked. So as Ministry of Health, we had to do everything as Ministry of Health with a few partners that were still inside, but majorly everywhere was locked. So we put up our response, we put up the labs, we worked with the community, we looked for the patients, we managed the patients. So by the time these shocks are coming, we are starting to learn to stand on our feet as Ministry of Health. Not, just like how a child starts, we wouldn't say that we are really firm, but they've come in an era where we have learned a lot of lessons from so many of the things that have happened to us as a Ministry of Health. The many epidemics that we've had to handle over time. Many times you start with your own resources before you run to any other resources. So what we've done now is we've recognized that we need to integrate our services, and we need to put the patient at the center of these services. So we are now implementing patient-centered health service delivery. So when you come, we will not see you as an HIV positive patient. We'll see you as a patient. If you have HIV, if you have malaria, if you have hypertension, this one health worker is going to sit and manage all the things that you have. We have done a lot of training since the stop work order from the US government came, just to bring all our health workers on board. We knew that at that time we had a lot of support from our US government supported implementing partners. They had put a lot of staff in our facilities that were helping us to manage the clients, but majorly in the HIV clinic. So now we've brought everyone together. We are implementing what we call the chronic care model, or the integrated service delivery model. So the health worker that is there, the capacity has been built for that health worker to be able to manage that patient sitting in front of her as a patient. Everything that they have, that one health worker is able to, look through them and manage whatever issue they have. We are looking inwards as a government. What is it that we can handle as government? I think you've heard already that the government of Uganda went ahead, even before this came, to increase our budget for ARVs. So for quite some time, we've been managing a big chunk of our ARVs. So, we know that the patients will not run out at any time, because government is putting money into that. It's putting money into test kits. And as we know, it has put money into our laboratory system, right from the National Laboratory Services at Butebo to all the other laboratory system across board. Most of the infrastructure, most of the accreditation, most of the reagents that they are using are actually supported by the government. So we are starting to look inwards. What can we bring on table? How do we bring it so that we stretch that little to be able to do so much more for our people?
All right, Kenneth, I want to take you back to on how hepatitis B is being eliminated in Uganda. I want to ask you: is there any challenges in accessing the hepatitis B treatment and also care services in Uganda? Do we have challenges in accessing those services?
Yeah, of course. Like even for the HIV that has had some significant external funding, they still have some challenges. So the funding that we receive for hepatitis B is domestic funding. So the government of Uganda has committed to support the hepatitis program, with 10 billion shillings every financial year. So you can imagine the whole program being allocated 10 billion shillings. That's very limited resource, and we advocate that the Parliament of the Republic of Uganda, through Minister of Finance, should actually rethink this, because there are a lot of things that are actually lacking because of the limited funding that we have. So the challenges that we still face with the hepatitis, like in the HIV, we have seen the stigma and discrimination. I can tell you that for hepatitis B, it's now doubled because of the low awareness that is in the public. There are a lot of myths and misconceptions, of course, which also arise because of the low levels of awareness. Even amongst the health workers, not every health worker will understand hepatitis B like it has been for HIV, because we do not have like routine trainings or workshops that are aimed at training these health workers to manage some of these infections. So as a way, we find that even some of the health workers end up giving not appropriate information to the patients, and then they end up being misled. But the other challenge to access, we have seen some challenges to do with the investigations or the tests. Before someone is initiated or is actually determined to be on treatment, there are a number of tests or investigation that a person has to undergo. And some of these tests, not all of them are done in public health facilities. So patients will be asked to go maybe in the private lab to perform these tests until they see the doctor or the health worker to determine whether they will require treatment or not. So in that way, we end up losing some of them to follow up, because if the patient does not have the money to do the test that is required for the health worker to determine whether they will require treatment, then they will end up, leaving. And that's why you see that the herbalists who advertise themselves for maybe having some drugs for hepatitis B end up receiving these patients, because for them, they don't require any kind of tests. As long as you tell them, oh, I have hepatitis B, oh, they'll tell us we have a cure. And so they just put you on treatment without even doing those tests that limit the patients from actually accessing the proper care in the health facilities. So the other thing is, of course, the medication. We have sometimes had some kind of stockouts for these medicines in some of the designated facilities that have to offer them. And that challenge also comes because of maybe lack of consistent supply of these medicines or products in the health facilities. Yeah, so those are some of the challenges, but we believe that with the current integration models, we hope that most of these will be addressed, and we pray that even our health workers in the public health facilities, even in the private sector, embrace the new models of integration, because even when the ministry talks about these and the people who are supposed to implement them at the primary health care do not buy in, then we shall still have these challenges. So my appeal goes to those health workers to ask them to understand the challenges we are currently grappling with of funding, and why we are now asking them that they should allow and have integrated services, so that if they see a hepatitis B patient and maybe someone has been entirely working on the HIV clinic, they should know that these are all Ugandans and they also need the services like any other Ugandan. Thank you.
All right, thank you so much. That is Mr. Kenneth here, Kabagambi, talking to us. And we also still have Dr. Linda Nabitaka, who is the Senior Program Officer, Elimination of Vertical Transmission of HIV, Syphilis, and Hepatitis B. Well, we are 11 minutes after 11 a.m. I want us to have a break, and we'll be back to continue with the conversation. Remember, this is UBC Ground Zero, and I'll be able to open up my lines in a short while. We are talking about strengthening the Triple elimination initiative of HIV, hepatitis B, and syphilis. We'll be back. Continue listening to UBC Radio Inspiring Uganda.
The Education Forum program. Education Forum, a platform for trends and developments in the education sector. We are your reference and reliable source of information. The Education Forum, right here on UBC Radio, inspiring Uganda.
Don't miss UBC Radio Ground Zero every Saturday from 10 a.m. to 12 p.m. We host credible and relevant guests to discuss pertinent issues of national importance aimed at addressing people's concerns. UBC Radio Ground Zero, right here on UBC Radio.
Welcome back. Ground Zero Season 2 continues.
UBC Radio brings to you the Timeline Radio Show, the space for civic and political rights for Ugandans. Tune in every Monday night at 10:15 p.m. to know the UBC Radio brings to you the Timeline Radio Show, the space for civic and political rights for Ugandans. Tune in every Monday night at 10:15 p.m. to know your obligation in society as a citizen. UBC Radio, inspiring Uganda.
Valuing the minimum standard which is expected of a public officer or a leader. This is nothing to do with declarations. It's how you behave, how you conduct yourself in office and outside office. Valuing.
I'm a chief. Yes. For my children are not disciplined, then I can't discipline other people because my children will be the role model of the community.
Valuing.
Because here the whole hullabaloo is caused by the introduction of the new lower secondary school curriculum, which is calling for research.
Valuing on UBC Radio, connecting you to the world of information.
Did you know that living healthy is the cheapest way to manage your life? A variety of research shows that a healthy lifestyle is the best medicine to live longer and stay away from diseases. Exercise is very important to our health. If you include exercise in your daily lifestyle, it improves your eyesight, normalizes your blood pressure, improves lean muscle mass, lowers cholesterol, and improves bone density. You can jog, skip a rope, or do some other activity that will keep your body agile. Research further recommends eating the right food. Try to eat a variety of vegetables daily. You can eat them in any way, either raw or boiled or lightly fried. Consuming high amount of vegetables reduces high risk of cancer in the lungs, colon, breast, cervix, stomach, bladder, pancreas, and ovaries. You can also lose weight by consuming a variety of vegetables, and it will also satisfy your hunger. It is also important to note that drinking enough water or staying hydrated is paramount to good health. Water helps in flushing out dirt, improving your digestion, activates the muscles, and regulates the body temperature. Keep drinking at least 3 liters of water a day for a healthy body. Remember, health is wealth. My name is Sentamo Rebecca.
Is independent sound.
UBC has 11 sister radio stations spread throughout the country to educate, inform, and entertain. Tune in to UBC Radio FM 98, your national radio station, Magic 100, where sports and music is our life. 87.5 Star FM in Uganda, 97.4 UBC West covering Western Uganda, 102 Mega FM in Gulu, 97 FM Butebo Radio in Eastern Uganda, 107.0 Buduri FM, 100.5 Ngea FM in Kasese, 98.0 West Nile FM in Arua, Total Ray Radio FM 90 in Karamoja, and 93.0 Voice of Mundubujo. Now you covered in your local language.
UBC Radio's inspiring Uganda. This is UBC Radio. Tune in for news.
At UBC Radio, we bring you Uganda's latest news and information.
Focus on Parliament.
What do you need to do to training for leaders of the before we finalize the budgeting process.
Enjoy sports, the environment, politics.
The mission we have is socio-economic transformation.
Health, entertainment, updates, and education on the farm. Keep tuned into UBC Radio, inspiring Uganda.
You're listening to UBC Radio Inspiring Uganda. We are 17 minutes after 11 a.m. and this happens to be the last hour of the Ground Zero on UBC Radio or UBC Ground Zero. And my name is Leki and I'm your host for today. And the second hour still goes on. We still have Mr. Kenneth Kabagambe here, the national organization. He's the ED, rather, the National Organization for People Living with Hepatitis B, project director as well, Triple Elimination Conference in Africa. And we also have Dr. Linda Nabitaka, the Senior Program Officer, Elimination of Vertical Transmission of HIV, Syphilis, and Hepatitis B. We're supposed to have a gynecologist, Dr. Gilbert Sendaula, and his numbers have actually been still having some issues, but we want to apologize him for that. So we are discussing strengthening the triple elimination initiative of HIV, Hepatitis B, and Syphilis in Uganda. And asked you guys to really get into the conversation. Send your messages on our WhatsApp. My WhatsApp is on 0776 511 426. Is the number you can call as well to share your thoughts on some of these issues affecting this country. They said if you have a dull, unhealthy population, the government will never be productive to make more, productive things. So join into the conversation. Feel free to also call again, 0776 511 426. Now, Monday, the 28th, will be the World Hepatitis Day. I will start with Kenneth. I understand there is hepatitis B, there's hepatitis C. I don't know. Give us a picture of what we really have in this country concerning that hepatitis disease.
Yes, thank you, Liki, and the listeners. So we have several types of hepatitis viruses, and these range from hepatitis A, B, C, D, and E. But all these have different modes of transmission, except for B and C, they kind of share the modes of transmission, but also they have different ways of management. For instance, with hepatitis A and E, these are fecal-oral infections, so you can get it through, consuming contaminated foods, contaminated water. So it's more or less transmitted like diarrhea or cholera, A and E. So for B and C, blood, body fluids that contain blood particles. That has to be emphasized, because when you say body fluid, someone might think even the sweat, because it is also a body fluid anyway.
Yeah.
So we don't want to cause chaos in the public. So basically through blood. Now with hepatitis, the difference between hepatitis B and C is that while hepatitis B has a vaccine, hepatitis C does not have a vaccine. And while hepatitis B is incurable for now, hepatitis C has a cure. So if someone has hepatitis C out there, currently the ministry is carrying out some project or program that is providing free medication to all those that have hepatitis C, and it is curable. So if you're out there, please, you might need to reach out to your regional referral hospital to check out on this program, because the Ministry of Health has that program in place. The other difference with hepatitis C is that it is more infectious. So for instance, we are told that if just one drop of blood for hepatitis C gets into a swimming pool and someone is swimming in the swimming pool with an opening, there is a likelihood that they would actually get the infection or the virus for hepatitis C. Now, hepatitis D only happens or only appears when someone has hepatitis B. So for those who have hepatitis B, they have higher chances of getting hepatitis D. So hepatitis D cannot exist in the absence of hepatitis B. So those are some of the differences. But with hepatitis A and E, they are not severe infections that should worry us so much, because the body itself, the body immunity can fight them off, and they are clear without causing any issues to the person. Except for the pregnant mothers, hepatitis E can make them get dehydrated, and they could even lose their baby, their pregnancy, or even also succumbing because of the dehydration that happens during that infection. So those are the different types of hepatitis viruses.
Okay.
So WHO has set 28th of July as World Hepatitis Day. And the reason is basically to re-echo and create awareness, momentum around these viral infections. And this year's theme is hepatitis. Let's break it down. And breaking down means, addressing the barriers to hepatitis elimination, and also ensuring that we emphasize the urgent need to remove the barriers to prevention, testing, and treatment, so that we reduce liver cancer and eliminate hepatitis by 2030. So in Uganda, we are not going to commemorate this day this month, but rather we shall commemorate the day next month in Pader, and the minister will be giving us the official date on when to commemorate this day.
Okay.
But as a country, our theme is it's time for action, and there has been a lot of momentum building around hepatitis, but now we are saying, let's walk the talk, and that's why we are saying it's time for action.
Okay, let's pick up some calls here. Good morning.
Good morning, Papa. How are you?
Good morning. How are you?
Good morning to our guests.
Good morning. How are you?
I'm fine. I'm called Juma. I'm calling from Buseka. We appreciate your effort on Ugandan health. Actually, I would like you to emphasize on the couple, the common person, the married people. How can we eliminate the high rate of hepatitis B among the people who are married? Then after that, we extend it to these other adolescent stages. We have our youth that are so active sexually. You at your home, from 7 p.m. no more movement. Children have to be at home. But these children, I think they are engaged in these sexual issues when they are, let me say, during daytime, some percentage during daytime, and maybe some few during those abnormal hours, and yet maybe parental care has reduced, single mothers are there, looking for what to bring on table in terms of food. By the time they are coming back home, a child has already done everything without proper guidance. So I would like, please, Ugandans who are coming from health sectors, could we have community engagement, bring workshop together, like those days we used to have those clubs, skate talk clubs, foundation at the primary school, even secondary school, and it will bring back the children who are still ongoing studying. They will know HIV is real, HIV can kill. Then the component of HIV/AIDS, those syphilis, gonorrhea, those small things, and above all, male circumcision. They should embrace that from childhood of a baby boy. Baby boy have to be circumcised, has got to be a healthy person. Though can acquire those other diseases, but at a low percentage. Treatment. hospitals these days, counseling teams are lacking. We don't have all hospitals with the counseling teams. You'll find one doctor who is supposed to assess the patient is the very one who is doing counseling job, which doesn't give you enough time to attend, like, let me say, 50 patients in a day. Because first of all, this doctor have to speak with the patient and ask the patient and chat with the patient to the details. So we also call upon government, if possible, all the NGOs to add more facilitation in terms of money to facilitate this program very well. And we pray for the betterment of this healthy generation of Uganda. I thank you so much.
Thank you so much, Juma, for your thoughts, please.
Amen.
All right. You can be part of this conversation today, 0776511426. Give us a call and share your thoughts on what we are discussing this morning, strengthening the Triple Elimination Initiative for HIV, Hepatitis B and Syphilis in Uganda. I have another call here. Good morning.
Good morning, sir. How are you?
Fine, thanks. How are you? Your names and where you're calling from?
I'm Robert. Yeah.
Robert, where are you calling in from?
I'm calling from Tinda.
Yes, talk to us.
Yes, what those people have been telling us, it is the truth. As me also, I have one of my sisters. He has that kind of sickness, that hepatitis B. So we went in the general hospital. They checked, then they said that they should start. They will start treating her. Then we went later on. They said that they don't have the medicine or tablet for medicine for that treatment. So I don't know how can we do. So I wanted that to know.
Yes, challenges in accessing some of the services. I don't know whether this is really true, but he says that they went to a national, referral hospital or something, and they didn't get medication. And do you think this is very common in Uganda, though, Kenneth?
Yeah, like I mentioned, these are some of the challenges that the hepatitis B patients continue to face, and until someone gets to the bottom, like goes to these health facilities. But when you speak to the national medical stores, they will tell you the medicines are there. But when you get to the communities, actually the public health facilities, the medicines are not there. So I think there is that gap in communication. Maybe national medical stores needs to work on the best way of training some of these health facilities in ordering some of these medicines, so that they get to the people that they need, that need them. Because it doesn't make sense for us to keep the medicines at the stores, and maybe sometime they can get to expiry. So that is taxpayers' money that we need to guard against being put to waste. So these challenges that they are telling you are not only in Kampala, but even in the rural setting. The districts that are far away from the national medical stores.
Okay.
Because this person has told you they are within Kampala. National medical stores from Kampala is just a few kilometers. So now just imagine the people in Kasese, the people in Arua, what they are facing. So again, my appeal is to the people who are responsible, who are in charge of ensuring that these supplies get to the people that need them, to make sure that they surely up the game and bridge some of these access challenges.
All right. Yes, good morning.
Good morning, sir.
Your names and where you're calling from?
Yes, we are speaking to Emma from Lira.
Emma, you're listening in from where?
Lira City.
Lira City. Talk to us.
Yes, it's like I wanted to know some other things. Because last year we are lacking some very many things. One day I could have, like one of my brother, he have a sickness of hepatitis B. But one day we went to the hospital. From there, they say that they doesn't have the medicine for help. But I don't know how you can help some other people from far distance.
Okay, thank you. Looks like people in the rural areas really do have these challenges. I think one or two can speak. If they've spoken, it means people do really have the challenge of accessing medical, supplies in terms of that. Yeah. So, Dr. Linda, talk to us. Publicity stands. Before I get there, I have another call here. Good morning.
Yes, morning.
Yes, your names.
Dennis.
Dennis, where are you calling in from?
From Zombo district.
You're listening in from Zombo. Talk to us, yes.
Is there effective treatment for syphilis where somebody has stayed with it for 20 years?
Effective treatment for syphilis? If someone has stayed with the syphilis for over 20 years? Yes,
exactly.
Dr. Linda will respond to that. Thank you so much. Your names again?
I'm Dennis.
Dennis. All right, thank you. Wow, 20 years. Don't tell us. What, can you stay with syphilis for 20 years?
I think one of the first...
Maybe before you say, let's put this last call. Good morning.
Yes, good morning.
Yes, your names?
Yeah, I'm called Jimmy.
Jimmy, where are you calling in from?
Just calling from Lukuli here in Kampala here. Thanks for the program.
Thank you so much for listening.
Yeah, can you give me some minutes? I'm among the victims there you are talking there.
Okay. What are you suffering from?
I'm being affected. I test for that sickness called hepatitis B 17.
Okay.
There are a group of people who are moving around. They were from Butebo. Then they tested me, I was positive. With my wife, but my wife is not positive. So they require me to go to the main hospital up to Butebo. Reaching there, they confirmed the same thing. But these people did not put me on medicine. Then from there, they told me to go and do this scanning. I did the scanning. They told me the liver is somehow okay. And then they refer me again from there to the second doctor to Kishwa. Reaching there, the doctor is not. But somebody who handled me again refer me to go and do what's the dosing I forgot the biology test in Ebenezer in the town. And each test was 40,000. So when I came back, then these people said that there's no medicine. Up to now, I'm not on the medicine, but now I'm feeling the energy going down. But that doctor wrote for me a medicine. I bought like each tablet was 2,000. So now I'm calling upon the government to work on that because we cannot afford to buy the medicine. It's expensive, and I'm here that every year they are talking 10 million. Thank you for the program.
Thank you for listening in. Kenneth, maybe a quick one before Dr. Linda comes in. We need to have a clear health facility that is doing a lot more for people living with hepatitis B. Is it Mulago Hospital? Where can they find this facility in Kampala, for example, for now? Under your umbrella, under your organization.
So the idea is at least every health center has capacity to manage hepatitis B patients. And that means that if a patient went to a health center 4, they should be able to find the medication. But I cannot guarantee this because you have heard it from the callers that when they get to these facilities, there are no medicines. The other one that I can maybe recommend, which again is a bit further from the community, is Chirudu. Chirudu is a hospital that is dedicated for management of hepatitis. At least that one I know. If any patient goes to Chirudu and they find challenges, maybe those are just general challenges that other facilities are facing. But if they get to Chirudu, at least they will be able to be worked on and helped. So, some of these challenges, when you listen to them, you really feel a lot of pain because the work that we have been advocating for the last so years, and we are still grappling with these challenges. Yeah, but I want to address the issue of a gentleman who called from, I think, Usega. He was asking us on how to address the issue of hepatitis B among married couples. Yeah, so the most important thing, for instance, is to know their status. we can't do any interventions before we get to know anyone's status. Like we said, hepatitis B has a vaccine. It's always important that people get to know their status. And for the adults, they should seek to get vaccinated. I've always said, and I will continue to say that for the adult vaccination, at least should be voluntary, because someone who goes and gets their first dose will be able to complete. Because the government was actually rolling out the free vaccination, but the uptake of finishing all these 3 doses was a huge problem. But if someone voluntarily went to the hospital, because these services are there anyway, they get the first dose. I believe that they will be able to continue and receive all their 3 doses than if we went to a campaign and gave people the first dose, then the second they don't come, the third they don't come. Because if you don't complete all the 3 doses, then you are not fully protected against hepatitis B, and that would be a waste. So I think it is better that we provide vaccines to adults who really are committed to finishing all their 3 doses, and that can only happen if they voluntarily go. Than for us, the health workers, to go to them. And then he also asked about the hepatitis B among adolescents. Like I said, the Ministry of Health introduced what we call the pentavalent vaccine in 2002. So if you look at 2002 to date, I think these people are now around 20-something years and above. So we assume, again I'll say assume, because you don't know whether there are studies that have been conducted to see whether these people have been 100% protected. Why I say that is because we still have some cases of that age category present with hepatitis B. So those, we assume that they have actually been able to receive the vaccine. But I don't think there is any harm if these adolescents went and checked themselves and still got the booster doses. There is no harm in that, to make sure that they are protected. So that is what I can say for now, and I thank the callers for raising these issues. From the calls, you can imagine that all the calls are coming and they are speaking about hepatitis. So that means we still have a lot of work to do as stakeholders in the space to ensure that we address some of these gaps. And for us as an organization, we cannot do it alone because we do not have the capacity anyway. Ours is just to do what the little we can within our means, and the rest will always remain with all of us, government and the citizens of this country. Thank you.
Yes, Dr. Linda. 20 years with syphilis. That is a very shocking news for me.
Okay. I think first I want to address the issues of the patients who have called who did not get services as they needed. I know, as we've all said with Kenneth, we have been improving our game with hepatitis with the evolving year. We were not doing so well in the beginning, but we have streamlined how we do things. We have streamlined the testing. We have streamlined the viral load testing. We streamlined the treatment. So as the caller said, they first tested in 2017. Very likely at that time, they were not even eligible for treatment. So most likely what the doctor said was, you're not eligible for treatment. We shall continue to monitor you. We monitor these patients after 6 months, then every year after that for hepatitis B. Not everyone who tests positive actually needs to start treatment immediately. And I think that needs to come out when people are given. But you know how anxiety is when someone tells you you're hepatitis B positive and then they're not giving you the treatment that you need. Sometimes you might not take it the way they are thinking about it scientifically. You think they've just not given you treatment. Okay. So it's important that people get the right information and that they actually understand where the health worker is coming from. Even sometimes when they say, you are not yet eligible for treatment, but we shall continue to monitor you at intervals. I have to say, even our monitoring has improved over time. Before that, things were not as they are now. There's still a lot of work to be done, but I think we have something in place. And when you go to all regional referral hospitals, all general hospitals, all health center tools, you should be able to get some degree of services for you to be managed if you have hepatitis. So for the patients who didn't get what they needed, I think you should try again. You're likely to get better services as when you go back now. And as Kenneth said, I think Chirudu, if you fail elsewhere, everywhere else, Chirudu should be able to give you the services that you need. Syphilis for over 20 years. I think syphilis is one of those diseases that have been, I wouldn't say abused, but almost every disease is called syphilis because they say kabotongo. Kabotongo when you have candida, kabotongo when you have syphilis, kabotongo when you have a rash of any kind. So there's always that assumption. And then because of that, people go and they are being treated for the wrong thing. It's actually not syphilis. Because for 20 years of actual syphilis, as I've said, you would be in the tertiary stage of syphilis.
Okay.
It would have affected your heart, it would have affected your nerves, and you'd be showing some, nervous system damage. And, you wouldn't be the same. But there are so many things that we label as kabotongo in our local language, and I'm sure even in the other languages, there are so many things that are labeled as kabotongo. So the most important thing, go to the right health facility, get the right diagnosis. If it's syphilis, the treatment is very simple and easy, and you will be managed. I want to go back to the first caller who talked about adolescent girls and young women. As Kenneth said, that age group, we are a bit more comfortable with hepatitis B because they've had their 5 doses of vaccine from 2002. So they probably are not as badly off in hepatitis B. We don't know. Maybe something that we need to look into. But then when it comes to HIV, that's where our biggest problem is now at the moment. We see that the most new infections are coming from adolescent girls and young women. And, even the boy child suffers a bit, but the biggest problem is the adolescent girl and young women. And we know that the best way to keep these children safe, for them not to get, HIV and other STIs, is to keep them in school. Of course, even in school, we have so many programs that talk to them about HIV, that talk to them about how they can prevent HIV. They have so many structural and social issues that make them very vulnerable, and then they end up getting HIV infection. Mostly because, they are dependent on other people. They do not have the funds, even when they need certain things. So they end up getting tempted to go beyond what they should do. And they end up in these very risky situations that lure them into situations of getting HIV. So our response for adolescent girls and young women has been really intensified over the years. We know it's the population where we need to go. We want to ensure that we support them as much as possible. The clubs that he's talking about, even in schools, we run those clubs, which are talking about both how to prevent, how to make sure that you don't get into the situations that would expose you to become vulnerable, and the available services in case you're in that bracket that is, at risk and vulnerable for HIV transmission. I think that's what I just wanted to add there.
All right. I still have many calls coming in. 0776 511 426. Please share with us your thoughts on what we have right now. Good morning. Hello. I think this one has gone off. 0776 511 426. Good morning. Hello.
Yes, good morning.
Good morning. Yes.
Good morning. Yeah, I'm Edmond from Pakwas.
Edmond, listening in from Pakwas. Please, can you move away from your radio? Or reduce the volume.
Okay. Yeah, I'm hearing from Papa.
Okay, talk to us, Edmond.
I've been a victim of hepatitis B when I was tested in 2015.
Okay.
Yeah. After that, we were trying to search for the treatment, but I couldn't make it because we went to the private health center.
Okay.
They told us that and then we were then stuck where I should go. So ever since there, I couldn't know where I can go because they not like they want where I've been now being used. So I wanted to know where exactly to start.
Edmond is stuck looking for the nearest health center. And Pakwach Hospital, I think, is just on the road. When you're driving towards Kampala, that one is, at least I know that hospital very well. So don't you think the easiest hospital is Pakwach Hospital? Maybe makes a bit of inquiry? Yeah, let's pick this other call. Good morning.
1 minute.
All right.
I appreciate my answers, but about the counseling teams whereby doctors being combined in doing everything, that one, none of them has given me the answer about the counseling. The agent for counseling deserves to be at either reception or any designated place within the hospital, partial with their views with the patient. And then another one, embracing male circumcision, which can really give healthy living among the boys before they become an adult. Because sometimes circumcision, when you already started 40 years, you had already acquired some of those other minor STIs, STDs, like we used to call STDs, which might be stopping a bus from the back. A bus has already gone, we are stopping a bus, which is late. At least when from a boy's childhood, from a baby, from a reasonable age, month, that you are ready to be circumcised, that would help.
All right.
Then finally, I will appreciate for the Uganda need mass sensitization countrywide. Some of the people who are within the central area, they can access the services. But mostly remote areas, reason being, our neighboring countries, their health movement, we Ugandans, we don't know.
Right.
Let me say I'm from Nebi, local bad. That one combined with the Congolese. You go the other side, South Sudan, Arua side. South Sudan combined with the Uganda. You go the other side down, that's Busia. That one Kenyan alongside. This side Mutukula, Tanzania alongside. So Rwanda are there. So you find that Uganda might fight for these diseases, but there are those people who are coming from within the East African countries. Ugandan health sectors have to do a lot. Thank you so much.
All right. I think you answered that already. Of course, you said clubs are in there, and you're emphasizing the issues of sensitizing the young generation, which is very key. And it says male circumcision. Is there any health system, of course, in the Ministry of Health? Do you have a line of male circumcision programs going on in assure him? I think that's the only thing he really wants to know, yeah?
First of all, I want to apologize for Juma for having skipped some of his concerns. We've been running a program for safe male circumcision for quite long as Ministry of Health. We do outreaches all over Kampala. We even used to set up tents in some of these roundabouts, Boise, Busega, and just encourage the men to come and circumcise. The response has not been as positive as we would have wanted, but the services are there. And now we've even restructured them into our regular services. So you don't have to wait for a camp. You don't have to wait for a particular partner. When you walk into our health facilities and you want circumcision, you will actually get circumcised. We encourage it a lot. We've majorly been circumcising 15 years and above, but we also encourage neonatal circumcision. If a child can be circumcised as early as possible, then the parents should go ahead and do that, not only for HIV, but as he said, for other, just to keep the child healthy in many other ways. Counseling, we have continued to support our health workers, even our regular health workers that you will find at the outpatient department. All of them have been given the basic counseling skills for them to be able to speak to a patient and support them. We've worked with the patient organizations of people living with HIV, organizations of people living with hepatitis, and we've supported them as well with skills to offer the basic counseling and to be able to support their peers, because we know even beyond the counseling skills that one has, lived experience, I think, is one of the best experiences that can help to support someone. So when you go to our facilities, you will find what we call the mentor mothers, the community linkage facilitators, the expert clients. They are there and they all offer, support and counseling services. Then when you go to the higher level facilities, we have what we call the medical social workers. And usually when your, issue is really beyond, then you are taken to the medical social worker who can support you with further, counseling and social beyond what the health facility can do to support you. So counseling is a key issue, just not for HIV and hepatitis, but everything health. Counseling is very very key.
Many people are actually still giving us a call. They really want to talk to you people, but of course, we're running out of time. And I don't think whether we'll be able to really pick all the calls. Good morning.
Hello, good morning.
Yes, your names and where you're calling in from, please.
Jennifer.
Yeah.
I'm so happy that finally somebody has talked about hepatitis B virus.
Okay.
And I am a victim.
Oh.
I have gone through too much that it is so heartbreaking. But going forward, I was diagnosed with this when I was in my early secondary school. And I lived with it without any problem. Because then I was told my body would clear the infection. But later on in life, when I wanted to have kids, that was when I realized I still have it in my blood. Okay? So anyway, I tried to look for help. What should I do? I live in Kampala. And there's, is it okay to mention some medical facilities, or I can just say medical facilities?
I think you can mention. This is a national radio.
Okay, I particularly went to Naguru.
Okay.
They were very good. I was shown to a certain doctor who handled me and sent me to the lab. Now, when I reached the lab, was where the headache came in. The tests are very expensive. That time they asked me for 80,000 shillings. I paid the 80,000 shillings, and then they told me the results will come out after 3 months. Okay? And already I wasn't feeling well and I was pregnant. Anyway, finally the results came out, and the viral load said it was not detected, which was very good. And recently, when I got pregnant again last year, I wasn't well at all. And I started looking around where I should go. I went back to Naguru. A lot of stories. You have to hold on for so long to get the results. And when the money they want, sometimes you don't have it. But finally, I had to zero to Kasanga to health center. Because when I was defeated with Naguru because of the money and everything, I started looking around. I was desperate. I went to Kasangati. Then I went to Viral. Is that Viral? I don't know how they call them. That department where they do viral load for that kind of infection. And then they took my load, and I was told. By the way, I thank those people. They didn't ask me for money. The lady told me it's going to take some time, but when it comes back, we shall let you know. It was hardly 2 weeks. She called me and told me my results were out. And then my results was reading 14,600. Okay, VALS. And then they told me I needed to see the doctor who will tell me what to do. But to date, I have not been able to see the doctor because the doctor comes twice a week. on Tuesdays and Fridays. But when he comes, he sees every patient, HIV, hepatitis B. All those patients, I think there's only one doctor. Okay? He is overloaded. They end up not getting anything at all. Up to now, I have my results. I don't know what to do with it. Okay? So anyway, my concern is I am so grateful that finally some sensitization is being made. And I'm very sure that I think something better is on the way.
All right.
There are so many people out here who are living like this. Others know, others even don't know. So if something can be done to help the whole general public to get to know their statuses and then get to understand that it is very important to test and find out our statuses, and it will help us to stay healthy, it will be a very good initiative. Personally, if there is anything I can do, me, I'm a lay person, I'm not a medical person, but if there's anything I can do, I would willingly do, because I have read about Hep B, I know what it means, I have the virus in my blood, I know how it touches, so I will be willing to do anything
to help.
Thank you for this.
All right, thank you so much. I wouldn't want you guys to respond to this because I'm running out of time. Monday is another day for us to talk about hepatitis B. All these calls, we'll be able to pick them up on Monday. Thank you so much, Dr. Linda, for coming through today, and Mr. Kenneth. We just have a minute to wrap this up. Another program is coming at midday, so I don't know.
Yeah,
a minute, just we wrap this up.
Yeah, I just wanted to give out my number.
Oh yeah, okay,
especially for those people who are living the hepatitis B.
Thank you.
Call me for counseling and all other things. So my number is 0702 23 0051. 0702 23 0051. Thank you so much for giving me the opportunity.
Linda, your takeaways, of course, about this program?
Thank you very much for inviting us to talk about this. We've had the voices from the patients. As I've said, we are improving our services with time. As the last caller has said, the first time she didn't get any help. The second time she got help within 2 weeks. If she went back now, even the midwives would know what to do for her, because over time we are continuing to build capacity of everyone to be able to manage everything as a Ministry of Health. As I said, we are moving into the patient-centered integrated healthcare services, and we have built capacity of everyone. So next time, they will not actually tell her to wait for the doctor. Whoever she finds there will be able to point her in the right place. Thank you very much.
Thank you so much, Dr. Linda, for taking your time coming here. And then Kenneth Kabagambe, thank you so much for taking your time coming to UBC Radio. Well, that has been UBC Ground Zero. My name is Licky. I'll be right back on Monday in the early birds. If all goes well, we'll be able to have another medical doctor to speak to us more about hepatitis B. For now, thank you so much. This is UBC Radio, inspiring Uganda. Until then, have a good day.
Every Saturday, UBC Radio broadcasts the Information Hub, your one-stop dial radio show. Join us to learn and know more information about innovations, research, and developments. The Information Hub, knowledge is power, on UBC Radio. It's hot.
We passed it. We didn't know exactly what the problem was on the ground. There is no pretending about the effect of this thing. There's no pretending about it. Nobody showed. It's a problem.
It's balanced.
This is not the stage at which you start planning to tax a commodity like coffee, especially from down there.
It's intellectually engaging.
The Constitution provides that the land must be registered under the National System, which is one of those that's recognized by the Constitution.
Ground Zero Season 2, live and syndicated on your public and national broadcaster, UBC, inspiring Uganda. That was Ground Zero Season 2, a production of Uganda Broadcasting Corporation, UBC, inspiring Uganda.